welcome. I am Dr. Aamna. I'm a resident in neurosurgery in Shifa Hospital, and the topic is hydrocephalus. This is our disclosure. This is a child with an enlarged head, with a large fronto-occipital circumference, thin scalp and dilated scalp veins with a sunset appearance of the eyes and a downward gaze and lid retraction. So if you see into the ventricles of this patient, they are enlarged. And after a CSF shunting procedure, this is the ventricular end of the shunt, and it is connected to the peritoneum with resultant decrease in the size of the ventricles. So hydrocephalus comes from a Greek word which means water in the head, and it merely denotes an increase in the volume of the cerebrospinal fluid and thus increase in size of the cerebral ventricles. CSF formation and absorption. CSF is formed by the choroid plexus and the ependymal lining of the ventricles, and it travels in the lateral ventricles, and via the foramen of Monro, it enters into the third ventricle and through the aqueduct of Sylvius into the fourth ventricle. And via a single median and two lateral apertures, it enters into the subarachnoid spaces, and it travels over the convexity of the brain to be absorbed by the arachnoid granulations into the cerebral venous sinuses. Hydrocephalus is generally classified into communicating and non-communicating. In communicating hydrocephalus, there is no, CSF can leave the ventricles, and the defect is in the absorption of these CSF in the arachnoid villi. Non-communicating hydrocephalus, also known as obstructive, there is a mechanical impedance to the flow of normal CSF, and the most common causes are mass lesions, which are compressing the ventricles from outside, or lesions present within the ventricles. Another group classified into special types, they are grouped with enlarged ventricles, group of conditions with enlarged ventricles, and not necessarily known to be as hydrocephalus, but they come as a differential diagnosis for hydrocephalus. And these conditions include a normal pressure hydrocephalus and hydrocephalus XVQ. And they have complex but poorly understood CSF flow dynamics. The causes for obstructive hydrocephalus can be acquired or congenital. Acquired causes include aqueductal stenosis, mass lesions, ventricles, hematoma or tumors within the ventricles, arachnoid cysts, and infections. Congenital causes include aqueductal stenosis, Dandy-Walker syndrome, or Chiari malformations. This is a CT scan showing a colloid cyst at the level of foramen of Monro, which is obstructing the flow of CSF from the lateral ventricles into the third ventricle with increase in ventricular size. This is an MRI showing a stenosis of the aqueduct of Sylvius, and CSF is unable to flow from the third ventricle into the fourth ventricle with resultant upstream dilation of the lateral and third ventricles. This is a Dandy-Walker malformation, which is characterized by a spectrum of posterior fossa malformations, including agenesis of the cerebellar vermis and incomplete development of the fourth ventricle, which is communicating with an enlarged CSF space within the posterior fossa. Over here, you can see a pineal cyst, which is also obstructing the Sylvian aqueduct and causing upstream hydrocephalus. This is a tumor in the posterior fossa, which is compressing the fourth ventricle. And due to compression of the fourth ventricle, there is upstream development of hydrocephalus. This is a tumor within the lateral ventricle, which is causing impedance to the flow of CSF and consequent increase in size of ventricles. So these were a few of the causes of obstructive hydrocephalus. The causes for communicating hydrocephalus may be infective, including tuberculosis or bacterial meningitis, which cause scarring of the arachnoid granulations and impaired absorption of CSF from the at the level of the arachnoid granulations. The other cause is subarachnoid hemorrhage, where the hemorrhage fills in the basal cisterns and the arachnoid granulations. Other causes include increase in CSF viscosity as a result of increase in protein production from CSF tumors. And another rare cause of excessive CSF production is choroid plexus tumors. This is an MRI showing communicating hydrocephalus, in which we can see there is enlargement of all the fourth ventricles, and it's caused by leptomeningeal glioneuronal tumor. Hydrocephalus ex vacu is a differential diagnosis for hydrocephalus. It results from compensatory enlargement of the CSF spaces. It is an asymptomatic condition which occurs in elderly people as a result of brain aging with related volume loss. It can occur due to pathological diseases causing brain shrinkage, like neurodegenerative diseases such as Alzheimer's. This is a CT scan showing encephalic volume loss secondary to ischemia with compensatory enlargement of the ventricles. Normal pressure hydrocephalus also comes as a differential diagnosis for hydrocephalus. One of the theories for the development of normal pressure hydrocephalus is a weakening of the ventricular wall due to periventricular white matter ischemic damage, which causes enlargement of the ventricles, although the etiology for hydrocephalus is not very well understood. It classically presents as a triad of symptoms, including urinary incontinence, deterioration of cognition, and gait disturbances. Although not all patients presenting with the condition may have these three symptoms. This is an MRI showing enlarged lateral ventricles with subependymal seepage of fluid, as we can see periventricular lucencies. Also, we can see enlargement of the sylvian cisterns, which transmits the pressure upwards towards the cerebral convexity, resulting in crowding of the sulci at the convexity. This is an MRI showing enlarged ventricles with periventricular white matter changes. So radiologically, we can diagnose ventricular Meckelli as an increase in Evans ratio, which is the ratio of the bifrontal diameter and the internal diameter of the brain. The normal ratio is 0.3. Increase in this ratio denotes ventricular Meckelli. Also, we can see widening of the temporal horns and an acute callosal angle. The callosal angle in a normal person is between 100 to 120 degrees, whereas in normal pressure hydrocephalus, it is degrees up to 50 to 80 degrees. So radiologically, we can see disproportionate changes in these subarachnoid spaces, including dilated sylvian fissures and a tight high convexity. Normal pressure hydrocephalus can be diagnosed by doing a simple outpatient procedure and draining around 40 ml of cerebrospinal fluid via lumbar puncture. If the patient shows symptomatic relief from the drainage of CSF, that is a good prognostic factor for after a shunting procedure. Idiopathic intracranial hypertension, also another differentiating diagnosis for hydrocephalus. It is commonly seen in obese females and presents with headache, visual problems, tinnitus, photopsia, eye pain, and papilledema. On MRI imaging, we can see dilated subarachnoid spaces. This is the optic nerve with increase in tortuosity, and we can see increased CSF surrounding the optic nerve. Papilledema can also be seen on an MRI with a flattening of the posterior wall of the sclera and inward bulging of the optic nerve head. This is an empty sella turcica seen in patients with idiopathic intracranial hypertension. So recently we had a female patient who had presented with headache and was being treated for migraine. And then she started developing visual deterioration. And we did an optic nerve sheath fenestration by opening the arachnoid membrane and releasing CSF. And prior to the procedure, she had only light perception in one of her eyes. And now, 2 to 3 weeks later, her vision is improving and she has got color perception and finger counting is present. Patients with hydrocephalus may present acutely, or chronic hydrocephalus presents with a gradual onset. In infants, acute presentation is with irritability, impaired level in consciousness, and vomiting. There will be a tense, bulging anterior fontanelle, a thin scalp with dilated scalp veins, a crackpot sound on percussion, and a sunset eye appearance where lid retraction and a downward gaze can be seen. Infants with gradual onset present with mental retardation and a failure to thrive. Adult hydrocephalus, acutely it presents with signs and symptoms of increased intracranial pressure, such as headache, vomiting, papilledema, and deterioration of conscious level. Chronic hydrocephalus presents with dementia, gait ataxia, and urinary incontinence. The radiological investigations that can be done for hydrocephalus include a skull X-ray. Over here, we can see convolutional markings along the skull vault. Also, we can see increase in the size of the skull and increase in the suture width. This shows a gyral imprint on the inner table of the skull, which is a sign of chronically raised intracranial pressure. CT scan imaging shows the pattern of ventricular enlargement, and it shows which ventricles are enlarged and is useful in the identifying the level of obstruction. For example, if there's enlargement of the lateral and third ventricles with the normal fourth ventricle, then the likely diagnosis would be aqueductal stenosis. If there is compression of the fourth ventricle, then it is likely due to a posterior fossa mass, which is compressing on the fourth ventricle. And in generalized dilatation, that is dilation of all the four ventricles, that would be indicative of communicating hydrocephalus. Ultrasonography could be done in MRI is done it will show us periventricular lucencies. Also, it is helpful in identifying the cause of hydrocephalus, as well as we can see microvascular changes. The management of hydrocephalus, patients who present acutely can be treated with an external ventricular drainage. Other options include ventriculoperitoneal shunt, third ventriculostomy, and lumbar puncture. Lumbar puncture could be done only in patients with communicating hydrocephalus, and any obstructive cause of hydrocephalus. Hydrocephalus, the options for treatment include a ventriculoperitoneal or a lumboperitoneal shunt, a third ventriculostomy, and treatment of the cause of hydrocephalus, that is removal of the tumor or any other mass lesion. This illustration is showing an external ventricular drain where a catheter is passed into the frontal horn of the lateral ventricle. And this catheter is then connected to a chamber externally that drains the CSF from the ventricles externally. This can be done as an emergency procedure, also can be done on the bedside under local anesthesia, and is a life-saving measurement. This illustration shows a ventricular peritoneal shunt. It comprises a ventricular peritoneal shunt in an adult, and the two ends are connected via a valve, which controls the rate of CSF flow from the ventricles into the peritoneal cavity. This illustration is showing the level of obstruction. If the obstruction is at the level of aqueduct of Sylvius, then the procedure of choice would be a third ventriculostomy, where fenestrations are made in the floor of the third ventricle, connecting the third ventricle to the basal cisterns. This is an endoscope and is inserted via the lateral ventricles through the foramen of Monro into the third ventricle. An opening is made in the floor of the third ventricle, which communicates the ventricles with the basal cisterns. This is an endoscopic view during ventriculostomy. This is a view of the lateral ventricle. Over here, we can see the foramen of Monro, the choroid plexus, and the septal vein. We enter via the foramen of Monro into the third ventricle. Over here, we can see the medullary bodies posteriorly and the floor of the third ventricle anteriorly. And an opening is made in the floor of the third ventricle, which via a Fogarty's catheter, which would communicate the ventricles with the basal cisterns. So these are the methods for treating hydrocephalus. Thank you very much.